What's up, everyone? Welcome back to the Daily Sean. For those of you who haven't been here before, my name is Sean. I do a daily video on something related to nursing. No rhyme or reason, probably not going to change. Fan question today: how to handle refusal of care. When you have a patient that you are assigned to, that you are caring for, decides to refuse care. This is kind of multifaceted. I had to think about this one for a minute. Think about my personal experiences as a bedside nurse. Think about my experiences as a nurse practitioner. Think about other areas of nursing, not just acute care, but in long-term care. And I actually think this question was about a patient in long-term care. They sometimes call them residents. How do you handle when your patient and or resident refuses care? The knee-jerk reaction is, seriously? You come into my facility, you're here in my facility wanting to get better, yet you're refusing the care we're providing. You don't want what we got? Then kick to the curb. Knee-jerk reaction, everybody gets pissed off at that. But you have to take a step back and put yourself in that person's shoes. Why are they refusing care? How well do you know the patient, first of all? Can you talk them through it? Can you talk them down? Can you negotiate with them? Do you know them for more than 6 hours? Maybe you've taken care of them for a number of days and you got to know them a little bit, maybe got to know their family or friends, their living and social didactics. So maybe you might be able to appeal to their needs and their priorities. A lot of times, I know that patients that have refused care for me in the past, I appeal to their family and friends. How would their family and friends feel if they refused this, if they denied this, if they're not getting better? How are they to spend the time with their family and friends? You can always use the debate of, if you do this, it's one step closer to getting where you want to go, wherever that may be. If negotiations don't work, then you are going to have to consider bargaining. Instead of fulfilling the entire intervention or the entire treatment, maybe you only do a partial treatment, or you give only half a medication, or you only are doing the therapy for a certain amount of time, or you're only going to eat this much of the food and not the whole tray. So you have to start bargaining. And bargaining is better than complete refusal. Lastly, at the end of the day, it is the patient and resident's decision. If they are passionately and adamantly refusing whatever you're giving them, medication, food, therapy, take your pick, IV, lab draws, whatever it is, they're ultimately that passionate about refusing the care, and it's not affecting other patients in some detrimental way, you're simply going to have to surrender on that one, because at the end of the day, it is their care, their life, their health, their decision. You, as their provider, their advocate, need to make sure you sell yourself. Make sure that you make yourself absolutely crystal clear about how you disagree with their decision. Their decision will not optimize their health in any way, will not optimize their situation in any way. You can actually give them examples of, if you don't eat this, if you don't do this, if you don't take this, what can or will happen. You can give examples. Depending on the patient's situation, you might be able to get away with scare tactics, and I caution you to use that sparingly. You have to know your patient very well, and you have to be very confident in what you're saying if you're going to use a scare tactic. In the ICU, we do use scare tactics, and it's not it's reality, and it's a blunt way of keeping them safe. For example, when someone's awake, alert, and we're weaning them from the ventilator, and they so badly want to rip that ET tube out of their mouth while the balloon is still inflated, while they're still on the ventilator. If you can, you tell them point blank, if you yank that tube out of your mouth, there is a high chance that you could paralyze or damage your vocal cords permanently, and you will never be able to speak again. Sure, we're embellishing to a small degree, but it is absolutely true. It is absolutely science-based fact that if you cause that kind of micro trauma to your vocal cords, you can damage them permanently. So sure, you could give the scientific reasoning behind it, but it doesn't have the same amount of punch if you simply say, if you decide to pull that tube out, you're not going to be able to talk anymore. That usually kind of opens people's eyes to, I know how uncomfortable this is, but I kind of like talking, so I'm going to try and behave as best I can. At the end of the day, you really have to know the patient. And sometimes that's unfair if you're just assigned to them. Heck, it sometimes even happens at the right at the beginning of the assignment, first thing in the morning, 8 a.m. meds. You've barely known the patient an hour and they're refusing to take medications. Have a plan in your head. For patients that are walkie-talkie, yeah, I know, ICU term. For patients that are walkie-talkie and that have the wherewithal to refuse, I'd say 75% of the time, their refusal for care is based on fear. Fear-mongering or fear from something they've read, seen, or heard. It's your job to clarify that. Hope this helps. Love to hear what you guys have to say about refusing care. How have you solved this problem in the past? What tips, tricks, and advice would you give to the tribe, to other nurses? What to do when your patient refuses the care you're providing? Inquiring minds want to know. Love hearing from you. Your comments are my caffeine. Share this with somebody. And as always, check your own pulse first.